This video is regarding Alvarado score of acute appendicitis. I want to talk about why do we even study about Alvarado score and why is it necessary? Why is it in the books? So Alvarado score was given in 1986, and why do we study about it? Let me mention that because I used to wonder about why are we even studying this Alvarado score, because when we have ultrasound, we have CT scan. So in reality, let's say you get a pain abdomen. Just because you have a pain abdomen, do you want to go through the process of getting a CT scan? Then it is expensive, it takes time, you have to drink contrast, it's not a very comfortable thing to do. Okay, and then so we would like to do CT scan only when we cannot make out whether it is acute appendicitis or not by lab tests and clinical examination or by ultrasound. So now, why don't we get an ultrasound done? That's the question. Okay, we can do ultrasound done if I have a patient who seems to be acute appendicitis, and if I have ultrasound facilities, I would definitely do an ultrasound and be sure that the patient has acute appendicitis, a big swollen appendix inside his or her abdomen, and then proceed for surgery. But let's say you don't have ultrasound facilities at that moment, or there's a queue in the radiology department and you're being given a date of 2 days later, and the patient cannot afford ultrasonography at other private laboratories and radiology centers. Now what do? You need a scoring system, because acute appendicitis can be quite confusing. Just because a patient has tenderness or pain in the right lower abdomen does not mean it is acute appendicitis. It is not something we can see directly with our eyes. And a lot of conditions can mimic acute appendicitis, like UTI, colitis, and many other things. So we want to figure out whether it is acute appendicitis, which needs an operative management mostly. We could do conservative management also, but we're still going to give antibiotics and many other medications. Or is it something else, like a UTI or colitis, for which the treatment is so different? So we want to figure it out. In a center where ultrasound, CT scan is present for theoretical purposes or for educational purposes, you can calculate the Alvarado score. But then later you're going to do ultrasound and CT scan, so it doesn't really matter. But in places like in rural areas or in places in hospitals where facilities are not that much available, or you don't have a ultrasound facility round the clock, you want to figure out whether this patient with particular presentation seems to be appendicitis or not. And if the Alvarado score is very high, we can directly take up the patient for surgery without doing any imaging. And you want to figure out whether the score is low or high. If the score is low, then it's not likely to be appendicitis. If the score is very high, it is definitely appendicitis, and we can proceed for the surgery. The chances of it being a negative appendicectomy is very less. If we get a score of 5 or 6 out of 10, then it could be, it could not be, then better wait for the imaging. And now let's go into the topic. Now Alvarado score, Alvarado is an 8-letter word, ALVARADO. So there are 8 parameters, and these go by the mnemonic MANDRELS, MANDRELS. So 3 of these are symptoms, 3 of these are signs that the doctor, physician examines, and 2 are lab tests. Now the 3 symptoms are: the first one, MAN. M stands for migratory pain. In appendicitis, there is migratory pain, not necessarily, but yeah, probably it's always a migratory pain, which starts somewhere around the umbilicus and later shifts to the right lower abdomen at the site of the appendix. The umbilical pain is a visceral pain in the T10 dermatomal region. And then when the peritoneum also gets inflamed by the inflamed appendix, then the pain shifts from the umbilicus to the right lower abdomen. So that's a parietal pain. And A stands for anorexia. The patient doesn't feel like eating. There's loss of appetite and all. N is nausea and vomiting. So if someone has migratory pain, you give a score of 1. For anorexia, you give a score of 1. For nausea and vomiting, you give a score of 1. So just by symptoms, a patient can get a score of 3 out of 10 for Alvarado score. Now the next 3 points are signs, which are tenderness, rebound tenderness, and E stands for elevated temperature. So if someone has fever, you give a score of 1. If someone has tenderness, what do you think? Is it 2 or 1? And about rebound tenderness, is it 2 or 1? A lot of people make this mistake. They think that tenderness is 2, and rebound tenderness is a classical feature that we always study about. Rebound tenderness can obviously be seen in other conditions also, but as a junior doctor, we always think about, oh, someone who has pain in the right lower abdomen, rebound tenderness, oh, must be acute appendicitis. So we tend to give a score of 2 for rebound tenderness, which is absolutely wrong. It's a score of 2 for tenderness and a score of 1 for rebound tenderness. Why is it like this? I will explain later. So we have a score of 2, 1 and 1. Now the lab test, you send a complete blood count CBC and with peripheral smear, and you will get these two results. L stands for leukocytosis, that is high WBC count of more than 10,000 white blood cells per cubic millimeter, and S stands for shift to left. Shift to left is a feature of a peripheral smear where you find immature white blood cells, immature leukocytes. And it's like, you make a diagram of the life cycle of cells from the left to the right. Obviously we write from the left to the right. So when you make it, obviously the baby white blood cells are drawn first, and then the mature ones, and then the old white blood cells comes later. So the whole picture shifts to the left, shifts to the immature cells. So that's why it's called shift to left. So there are more of the immature, the proportion of immature cells in the peripheral smear increases. And so leukocytosis gets a score of 2 and shift to left gets a score of 1. So it's a total of score of 10, and there are 8 parameters. 6 have a score of 1, 2 have a score of 2. So if someone has all these features present, it is highly likely to be, or we can say, confirmed appendicitis. So if in the books it is written in such a way that 9 and 10 is confirmed, and 7 and 8 is highly likely. 5 and 6 is equivocal. That means we cannot say anything. We should wait for the we should do the imaging studies like ultrasound, and if that does not detect, if still we are confused, we should go for CT abdomen. And 4 or less is very less likely to be appendicitis. Now, why leukocytosis and tenderness gets a score of 2? So it's like, let's say one patient has everything is positive. You remove, let's say this patient has rebound tenderness. It's an imaginary patient, okay? This patient has rebound tenderness but no tenderness. That's a score of 8. Now this another patient has tenderness but no rebound tenderness. This is a score of 9. So the meaning of this is that if someone does not have tenderness at all in the right lower abdomen, then the chances of that condition being appendicitis decreases more than someone who does not have rebound tenderness. So rebound tenderness is a late sign in appendicitis. It comes later. How can someone have acute appendicitis without tenderness? It's very less likely, right? Just think about it. So if there's no tenderness, score drops quite more than the score should drop for the absence of rebound tenderness. So remember like that. So tenderness is 2, rebound tenderness is 1. Someone doesn't have rebound tenderness, okay, fine. It could still be appendicitis. Someone doesn't have leukocytosis, okay, we need to think about it. So see, so if someone doesn't have tenderness and leukocytosis, these are signs which should most probably be present in acute appendicitis. So these are given a score of 2, and the others, they may be present, they may not be present. Presence or absence of one of these parameters does not really make a difference, so they get a score of 1. But you should remember that this is not a foolproof scoring system. It was given by some doctor or individual. Obviously it is not a foolproof thing. It just helps with your clinical diagnosis in the emergency department. and you can take a quick decision without waiting for radiology, for imaging studies, whether to take up this patient for surgery or take the patient to the ward and start treating as a case of acute appendicitis, or wait or send the patient home. I hope you enjoyed this video. Thank you for watching. Don't forget to subscribe to the channel and click on the like button, because it helps recommend my videos to other people by YouTube. Thanks a lot.